Welcome everyone, and thank you for joining us. This is the webinar. This webinar is part of our RUNX1 Research Program's Medical Education webinar series. I'm Katrine Erickson. I'm the Executive Director of the RUNX1 Research Program, and I will be your host today. So again, welcome. Next slide, please. Before we jump into the program, I'd like to briefly share a little bit about RRP, as some of you may not be familiar with who we are, and then also share some available resources that you might find valuable. We are a nonprofit that is dedicated to supporting patients with RUNX1 familial platelet disorder. We were started back in December of 2016 by a family affected by RUNX1, and the mission has stayed the same since then, and that is to improve the quality of life and prevent blood cancer in RUNX1 FPD individuals. As many of you probably already know, RUNX1 FPD patients have a close to 50% lifetime risk of hematologic malignancies, and the most common is AML and MDS. Our strategy in achieving our mission doesn't only include hosting medical education webinars like these, but also it includes supporting our patient community through education, through research collaboration, and through community building. But the majority of our funds actually goes towards research grant making. And thankfully, with a number of amazing nonprofit partners, we've been able to make a pretty big impact. So we have partnerships with groups like Alex's Lemonade Stand Foundation and the American Cancer Society, which has enabled us to commit over 16 million in research dollars towards understanding this disease and towards discovering blood cancer prevention treatments that I think have the potential of actually being applicable to other predisposition syndromes as well. So you can imagine that this webinar series is really important because it focuses on the underappreciated prevalence of germline predispositions to hematologic malignancies and how to diagnose them in the pediatric setting, and why that's so critical to our mission. So really, our shared goal today is about improving the diagnosis of families by diagnosing individuals as early as possible so that we can actually have the potential of preventing the onset of blood cancers in the future. Okay, now to the QR codes on the slide there. The first QR code on your left is a resource we created with a wonderful nurse practitioner named Karen Brundage, who spent most of her career at Boston Children's Hospital and has performed hundreds, if not thousands, of bone marrow biopsies. And in this resource, it's really just a simple two-page, two-sided one-pager. And the goal is to help providers with tips on how to improve the experience of bone marrow biopsies for patients. And the reason we set out to create this one-pager was because one of the chief complaints we hear from families in our community is the extreme pain and discomfort they often experience with the many, many years of bone marrow biopsies that they've had to endure. So we thought maybe we could learn from someone who's done them a lot and see if there are any sort of clinical pearls that could help. On the right is another QR code, and that leads you to a page about our RUNX1 Inherited Hematologic Malignancies Consortium. This is a consortium that is international and includes a group of non-malignant and hem-onc physicians, both adult and pediatric. It also includes pathologists, geneticists, genetic counselors. We have a very, very active genetic counseling working group within the consortium. And really, this group works together to drive forward clinical research progress as a collaborative network. And currently, they're focused on RUNX1 FPD clinical consensus guidelines, but the goal here is this consortium is really broad. And I know there's one group already focusing on ANCHR-D26, and so it's really meant to create a network focused on these germline predispositions to heme malignancies. Okay, next slide, please. Thank you for your attention and for allowing me to share a little bit about RRP. And now I have the pleasure and honor of introducing Dr. Serine Avagyan, who is our main speaker today. Dr. Avagyan has been a really, really active member of our RRP research community, and she is a very passionate pediatric hematologist oncologist who specializes in the care of children with myeloid cancers. She is an assistant professor in the Department of Pediatrics in the Division of Blood and Marrow Transplantation and at the Eli and Edith Broad Center of Regenerative Medicine and Stem Cell Research at the University of California, San Francisco. Following Dr. Avagyan's presentation, we will have a 15 to 20-minute Q&A. And that discussion will not only include Dr. Avagyan, but also will include Dr. Vivian Chang from the University of California, Los Angeles, and genetic counselor Kayla Hamilton, both of whom I will introduce more formally at the time when we start the Q&A session. Just a quick reminder before we start the presentation, please feel free throughout the presentation to pop in your questions in the little Q&A icon whenever you'd like, and we'll then have a nice list of questions to discuss at the end. Okay, without further ado, I'm pleased to welcome Dr. Serine Avagyan.
Thank you very much for this introduction and an exciting opportunity to share with you some of the ways that we think about the workup of patients with hematologic malignancies and how to recognize hereditary aspects to this. I'm just going to hide the video panel so I have all right, here we go. So I guess the main objectives to go over some of these very quickly at the beginning is going to be discussions, case-based encounters to discuss clues and some tools that we could use towards identifying these hereditary hematologic malignancies, and really no order of importance. This will include specifically a discussion in somatic landscape of cytogenetic and genetic alterations as being one of the keys, some features of the disease, particularly related to the pathology, the preceding cytopenias, and perhaps the recurrence patterns of the disease that could be used towards this, family history considerations, and we'll mention briefly some non-hematologic manifestations, some of these syndromes that will be also important. I do want to mention that all of these, and perhaps even more topics, are themselves like an hour presentation each, or pages of review. So by no means this is going to be comprehensive to a point that will be sufficient to cover the whole entire topic. So as a way of introduction, I do want to stress the importance of recognizing that there's increased incidence and recognition even that germline predisposition underlies early onset blood disorders, which includes children up to the age of 18, but also young adults that typically, considered up to age of 40 years. Typically, the red flags that we think about with patients having an underlying condition would be, for example, the presence of first and second degree relative with hematologic or solid tumor cancers. The history of personal malignancy in the past, whether that might be hematologic or non-hematologic, might clue us into that. Certainly, the presence of immunodeficiency or preceding cytopenias often make us think whether there was a preceding process, for example, a systemic process that was affecting hematopoiesis in general that could be contributing. More and more often, as somatic panels are part of the workup of presentations in blood cancers and blood malignancies, gene variants that might be close to heterozygous clone size are sometimes cluing us in that these conditions might be part of the process. And certainly, historically, this physical stigmata and more recognition of non-hematological features of this conditions or specific conditions can clue us in as well. But I guess the key points that are really important to remember is that the germline predisposition can really underlie blood disorders at any age. So you might be taking care of a teenager and know about a family history in a 67-year-old person that should absolutely contribute to your thinking. So it doesn't have to be specifically in an early onset nature. And really, the important part is that the lack of any of this above that I just mentioned really does not rule out germline predisposition. And the constant suspicion is really what probably leads very often to this discovery. And as we go along in the presentation, I will point to these key features in these purple squares or rectangles in the sidebar, just to kind of maybe prompt a little bit more attention to those points. So a few words about the incidence of these conditions, and these numbers by no means are ones that are set in stone, and this is quite dynamic as a field. And but based on literature that is as up to date as I could possibly come up with for today's topic, is these are really the typical percentages that have been reported, and BALL being the lead type of hematologic malignancies in children may encompass about up to 5% disease that is related to germline condition. TLL and AML, as shown here, a little bit less common, might have 3 to 5%, and AML a little bit more. So myeloid cancers have a little bit more incidence of germline predisposition, that can be up to 15%. Now, the story becomes a little bit more profound and may be critical to recognize in conditions like myelodysplastic syndrome, where the incidence of germline conditions can be up to a third. So, percentages like 30% have been reported in literature. And most critically, in this very small subset of BALL called low hypodiploid ALL, which we'll come back to, the incidence of germline TP3 mutations may be up to 50%. So the disease itself can gauge that preterm probability, pretest probability of this, the disease having an underlying germline condition. So the why is quite an important aspect to this discussion, and I think as a physician, as providers that are taking care of these children, for me personally, one of the most important things is the proper diagnosis, and I think this has been recognized now also in the classification of myeloid and lymphoid neoplasms, where there's a dedicated section to hematologic malignancies with germline predisposition. In addition to the proper diagnosis, this obviously leads and is tightly connected to optimal treatment and conditioning, whether that might be chemotherapy or conditioning regimens for stem cell transplant, with a main goal to reduce non-relapse complications and toxicity. For example, in conditions like Li-Fraumeni syndrome or telomere biology diseases, that becomes quite important. Another aspect to why it is important to diagnose these disorders is that the donor selection for a stem cell transplantation, which very often is the curative means for this patient's diseases, should avoid getting the stem cells from a donor that is affected by the same condition, right? In order not to transplant the same disorder back to the recipient patient. And indeed, this leads to very important considerations of family member testing and counseling, and specifically even for the patient themselves, genetic counseling and family planning for the future. And lastly, as we learn more and more about the non-hematopoietic features of some of these conditions, the anticipation of these complications is important and sometimes really contribute heavily to the morbidity, and sometimes, unfortunately, the mortality of these patients, even after the fixing of the hematopoietic system by stem cell transplant. So with that, we'll just dive into the cases right away, so we can have a platform and specific examples to discuss. So case one is that of an 8-year-old girl with a 3-month history of intermittent cones. So nothing specific. She is not herself, as the parents report, which can be, quite informative and not very helpful sometimes, but this is an important aspect to this story. There's a family friend who had not seen her for a few months and maybe mentions that she looks a little pale to her. And the family very promptly sees their pediatrician, who obtains basic labs. So previously, the child has been healthy with normal growth and development. There is a history of breast cancer in her mom. So mother was diagnosed with triple negative breast cancer in her early 40s. And at that time, she had a testing that was reported to her as being negative, genetic testing for inherited cancer predisposition genes. Her father and her 2 siblings are healthy. So the physical exam is notable for a mild pallor. There's no organomegaly, and otherwise the exam is unrevealing. So the laboratory values that you receive as a hematologist or an oncologist is the following. So she has some leukopenia with a white count of 2,200. She's anemic with hemoglobin of 9.8. The mean corpuscular volume, the MCV, is quite high. It's at 103.5, and her platelets are low at 85,000. She has mild neutropenia at 1120 and some lymphopenia as well as low monocyte count, but there are no abnormal cells or blasts on her peripheral smear. So even from this very quick vignette, there's two very important aspects that I'm sort of filing and thinking about as I'm thinking about her case. One of them is this positive family history of a non-hematologic cancer, so this early onset breast cancer in the mother. And the second one is this very obviously profound and obvious multi-lineage cytopenia with ANC, low platelets in hemoglobin, but with very also notable macrocytosis, so large red cells, which is a little bit unusual for aplastic anemia, for example, that is mediated by immune destruction of stem cells. So the referral to the hematologist oncologist is prompt. That leads to a bone marrow evaluation within a week. And so the pathology in this case shows hypocellular marrow with up to 20% cellularity in some patchy areas. There's no increase in CD34 blasts, but there is an abnormal population of c-KIT or CD117 positive myeloid progenitors that corresponds to the flow cytometric analysis. And there's a few dysplastic megakaryocytes that is noted by the pathologist. She has a karyotype or cytogenetics, which is pretty standard in this kind of evaluations, that shows that 9 out of the 15 colonies are missing chromosome 7, that is consistent with loss of chromosome 7. And the FISH panel that is done in this particular sample corroborates that with a positive monosomy 7 finding in 40% of the cells. There's a somatic leukemia panel that is done, which identifies 4 variants. 2 of these variants are in GATA2, the other 2 in WT1. One GATA2 variant is at a variant allele frequency or a clone size of almost 44%, and it's reported as to be pathogenic. And of note, all the variants that I'll show you throughout the talk, except for when it's not the case, they all are going to be pathogenic or likely pathogenic. I won't list them every time, but just know that that's how it was categorized in the reports. So again, just looking at the key points of these information that we have a hypoplastic, hypocellular marrow, but with presence of dysplasia, which is again something that should clue us in that there's an abnormal process happening in the marrow. The finding of monosomy 7 is going to be quite critical to think about, and of course, this GATA2 variant in a somatic panel that has about heterozygous variant size, close to 50%, plus minus 15%, is what clues us in what might be going on here. So this case was diagnosed as monosomy 7 myelodysplastic syndrome, of MDS, because of the hypocellular marrow, the monosomy 7, and the dysplasia. And indeed, the concern with this, with the GATA2 variant 1, was that it might be a germline contributing to the pathogenesis. And she had a germline panel testing initially, but at the same time, concurrently a buccal swab, which confirmed that this particular variant was actually germline. And this case was then the final diagnosis would be GATA2 deficiency associated MDS with monosomy 7. Now, because the treatment for this is very promptly to plan for a stem cell transplantation, which is the definitive curative therapy for this, her family members who are HLA type, HLA matched siblings, and the parents who are haploidentical were actually tested for this variant in order to, as I mentioned, to identify the appropriate donor. And in this testing, it was found out that the mother who had the triple negative breast cancer was the affected parent in this case, and carried this variant in her buccal swab. And the interesting twist in this story was that her blood sampling actually at the time showed that the variant allele frequency of this germline GATA2 variant was 4%, which is suggestive that she had experienced what's called a somatic genetic rescue and reduced that mutant clone size in her blood over the 40 plus years. So, one quick key note here is that germline testing ideally should be done on cultured skin fibroblasts, which is the non-hematopoietic tissue that is very often probably considered as a gold standard in the testings like this. But really, that's when time allows. And a lot of times when these children have to proceed with a stem cell transplantation, and the donor evaluation is an important part of that process, alternative methods of more quicker turnaround tests is used, such as buccal swab testing, skin biopsies more recently, and often hair follicles. And in some areas and institutions in Europe, nails are used as well. And then the second piece, as I already mentioned, that the cascade testing for family members really is prioritized depending on the clinical care and the donor selection process. This is not to say that the remaining family members should be forgotten, of course, but sometimes the time sensitive nature of this is quite important, and prioritization and focusing the family's attention to the members that perhaps are critical in the care of the patient is important. So a few words about monosomy 7 and 7q in pediatric blood disorders, as this is one of the most common genetic alterations in non-lymphoid and non-lymphoid blood malignancies. This can be a loss of chromosome 7 completely, or maybe a partial loss of the long arm of chromosome 7 by derivative 1,7 or a deletion of 7q. I think personally, to me and perhaps many of my colleagues, this on its own actually has a high value, positive predictive finding for germline hematologic malignancy predisposition conditions. And the reason is that, almost every bone marrow failure condition that has a leukemia risk, a lifetime leukemia risk, has been associated with monosomy 7. Now, the top two conditions to think about is GATA2 deficiency, which is the case in our first case. And the second one is a SAMD9 or 9L syndromes, which both have a pretty high incidence of monosomy 7 disease. But again, as I said, most, if not all marrow failure and leukemia predisposition conditions have been described with this pathophysiology, maybe rarer in Diamond-Blackfan anemia, and perhaps even rarer in pediatrics associated with telomere biology diseases, but certainly has been described. And 2 words on GATA2 deficiency pertaining to this case. It is inherited through an autosomal dominant pattern through heterozygous variants or deletions, and the variants have been described in all parts of the gene, most commonly in the zinc finger regions of this transcription factor, but really everywhere else in the gene, including deletions of portions of the gene and whole gene deletions, which are important to keep in mind, as well as intronic enhancer deletions that reduce the expression of the gene. This is one of the most common causes of adolescent or pre-adolescent MDS and AML. As you can see here, almost all types of variants can cause AML or MDS that have been associated with it. But the spectrum of disease has really spanned from anywhere, from lymphoid cancers to JMML, MDS, and AML. So it's not restricted to a particular type per se. And one aspect of the immunodeficiency related to GATA2 is that it actually often presents with monocytopenia, as we saw in our first case, and B and NK lymphopenia. So the importance of understanding some of the immune patterns in these diseases is also critical. There's high incidence of atypical mycobacterial infections and warts that sometimes can be that clue you in to think about the MDS or AML differently. And some other manifestations include pulmonary alveolar proteinosis that is thought to be related to macrophage dysfunction in this disorder, and some non-hematopoietic features such as lymphedema, hydrocele, thrombosis, and others. And I have the link here to a fact sheet that is really useful, put together by the NIH for your review. The case 2 is that of a 21-year-old young man who has leukemia, and there's concern for relapse. And the history of this gentleman is that he actually was diagnosed with BALL at the age of 15 with a BALL that it's called PH-like. The actual diagnosis here is not important. The genetic analysis actually showed these findings that are pretty typical for PH like BALL. There's a rearrangement in a gene called CRLF2. There's a small variant in AZH2, JAK2 variant, and IKCF1 variant at 87%, and a copy a loss of 7p that includes IKCF1 as well. There's a couple of deep deletions that is found on SNP array with 9p and 13q. And again, because neither the pattern or the actual diagnosis at this age of BALL is not unusual, he proceeds with receiving the appropriate therapy as per Children's Oncology Group protocol. Again, not important for the discussion of this case. Now, unfortunately, 3 years after the end of ALL therapy, he presents to the emergency department with shortness of breath and is very quickly found to have pancytopenia, so low blood counts in all lineages, and is diagnosed with leukemia with concern of relapse. And the genetic studies of this leukemia, the second leukemia in him, shows the same IKZF1 variant that was seen in the first time in his first ALL at 51% varying allele frequency, a PAX5 variant that is new, IL-7 receptor variant that is also new, and the same deletion of 9p and 13q at 50% by FISH. And again, given the IKZF1 variant recurrence and the pattern of different genetics in this particular disease, the concern comes up for a germline IKZF1 condition or a deficiency, and a buccal swab is sent that confirms that the IKZF1 variant is actually germline and is responsible probably for the second cancer. So the key points here that I want to pay attention to and discuss briefly is the interpretation and explanation of the clone size. So if we see a variant, for example, IKZF1, that is one of these overlap genes between both somatic leukemogenesis, but also germline leukemogenesis, it's important to understand how this number came to be, right? So, the 87% clone size is probably a combination of having an already first hit, so the heterozygous IKZF1 variant, and an additional copy loss of the wild-type IKZF1 on the other chromosome. And so kind of digging into the actual numbers of the VAFs of the variant sizes of the clones could give a clue, at least kind of have a sense that perhaps it does not make sense if this was a somatic mutation only. And of course, the second important point of this case is this different genetic somatic pattern of the second malignancy, even though it has some sense or some findings that are shared between the two. It's just the suspicion of this being related to germline condition is what I'm trying to perhaps underlie here. Is not that it has to be given. This may have been a relapse cancer with just a different type of genetics, but the suspicion for this being germline comes from this different pattern. So 2 words on the IKCF1 gene and other lymphoid leukemia genes. These are overall rare, as far as we know and understand today. There are 2 groups of categories of genetic polymorphisms that have been described. One of them is a common polymorphism that are in a lot of the genes that has been described to date at a very active research front, and it's incredibly exciting, which aims to understand the multigenic contribution of various genetic variants to high risk leukemia development. And we're not going to talk about these today. But the second group is actually the rare variants in very similar genes, actually, a lot of them the same genes, that have a high penetrance susceptibility. And these are the 4 listed here, and they all have an important role in the development of B cells from HSCs through lymphoid progenitors to pre-pro B cells and pre-B cells, as depicted in this graph. So IKZF1, perhaps underlying up to 1% of BALL, we talked about in this particular case, sometimes also has immunological phenotypes. So there's immune deficiencies associated with this genotypes, and there might be neutropenia depending on the variant. This is a very confusing, actually very interesting gene in itself, and very often also occurs with the somatic IKZF1 deletion. So again, skewing that clone size that can be a clue. A very similar pattern is seen in PAX5, which is much rarer than Icarus deficiency, and it can also occur with somatic PAX5 deletion, which is in 9p, and sometimes the actual report or the FISH might not say PAX5 deletion, but it notes 9p. So it's kind of important to make that connection between the gene and the loss of chromosome. ETV6 and RUNX1, both of them are related to thrombocytopenia and actually myeloid malignancy risk. But again, both of them have been described in BALL and RUNX1 also in TALL. And interestingly, ETV6 is associated with more hyper-diploid BALL. And RUNX1 is, as I said, is more commonly seen as as underlying TALL in a large study that is quoted in this review. I don't have the specific study name on the slide, but you will find it in this review. And the TALLs in this particular case actually very interestingly have a quite unique somatic JAK3 variants that might be important in this pathogenesis and often present as ETP, so early thymic progenitor phenotypes, and that can also be a clue in terms of the uniqueness of the combination. We'll go to case 3 with this, which is that of a 12-year-old boy that has easy bruising with activity. He's a soccer player. Not a big deal, soccer player, bruising, not really unusual, right, in that sense. But the mother is very concerned about this. And the reason is because she herself, not being a soccer player, has easy bruising. She had it in childhood. Maybe it's a little bit better now that she's an adult, but she certainly remembers that being part of her childhood. And furthermore, her own mother, so the grandmother of this child, who was recently diagnosed with myelodysplastic syndrome and underwent stem cell transplantation, also had noted to her physician that she remembers having easy bruising when she was a child. And again, this was very promptly picked up by the physician, the adult provider of the grandmother. And there was a concern for RUNX1 deficiency because of this thrombocytopenia, easy bruising, and MDS susceptibility. There is a somatic cancer panel that is sent with this concern, and it comes back negative. But the provider, being still quite astute and concerned that this might be certainly related to RUNX1, actually sends the buccal swab from the grandmother to a germline panel testing. And this particular testing indeed identifies a heterozygous RUNX1 exon 1 to deletion, which certainly would not have been picked up by the somatic panel. And one of the key aspects to this particular case to mention is this fact that negative somatic panel testing does not rule out germline conditions, because many of these do not include copy number assessment and will miss deletions, large deletions, or duplications in the gene that are certainly important aspect to the pathogenesis and the diagnosis of the condition. Now, this child at the 12 years of age, he's well, again, other than the easy bruising, I think his platelet counts were actually pretty normal even, is having a marrow evaluation because this recommended this time to get a baseline, at least marrow without any concern of disease. And this is what you get in the report, that there's actually dysmegakaryopoiesis, or dysplasia of megakaryocytes with this separated nuclei, abnormal looking megakaryocytes. This is not his marrow. I took this from Dr. Calvo's review that is referenced here, but this would be a quite typical finding, for example, in this particular disorder. I just told you a couple of slides ago that dysplasia is one that you want to be concerned about. However, dysplasia may be normal in some of these conditions, in some germline conditions. So understanding baseline appearance or morphology in these conditions, through family history in a child that is perhaps healthy at this point, is quite critical, because the change in that dysplasia is what actually prompts us to think about disease transformation instead of the actual just absolute presence of this dysplasia in it. So towards a RUNX1 familial disorder, it is an autosomal dominant inherited disease that is one of these inherited thrombocytopenia syndromes that is associated with increased lifetime risk of hematologic malignancies, as Katrine mentioned a few minutes ago. So the group of these disorders that we think about include these 5 genes, anchoring D26, ATP6 that I mentioned before already, MECOM that usually has an early onset, RUNX1, and most recently described ERG. And one of the important findings, maybe most recently from the natural history study of RUNX1 FPD, was this bimodal distribution of neoplasms, first being in the, sort of the first wave being in the first decade of life, and the second being later in life in the fifth, sixth decade, which is a more typical sort of adult onset MDS and AML timeline. Now, the really interesting finding that I thought from this study was that in children, despite the fact that they're coming or stemming from the same germline risk, the myeloid cancers a lot of times had a chromosomal abnormality, which is more typical for children or sort of early onset blood diseases, versus single nucleotide variants that is more typical in adults and certainly seen also in RUNX1 FPD. So even though even though the germline condition is the same, the somatic pathology or the pathogenesis is quite divergent and more true to the age of the patient. So neither should make you kind of disprove the presence of a germline condition, because that can have differences in presentation. And with incomplete penetrance and really the high suspicion is what leads us to think about some of these older adult onset MDS AMLs and think about our own patients in pediatrics and how to put together those two, and really consider the presence of these cancers in all three generations of the family to raise our suspicion. And a couple of other disorders that I just mentioned here, but certainly this is not limited, that typically adult onset diseases might be also in telomere biology diseases, in DDX41, and so that again should clue us in despite their older age onset. And the case 4 is a very peculiar one. This is our last case that we'll discuss, and that's of an 11-year-old girl who presents with a really long and quite kind of a discomforting history of lower extremity pain with negative musculoskeletal workup. She has had no personal or family history of any type of health issues, including solid or liquid cancers, and her labs are not very impressive. She has mild anemia for her age, maybe related to the high inflammation. Again, nothing, spectacular, but the bone marrow evaluation is eventually done because of this abnormal looking osseous lesions that is seen on imaging. And very curiously and perhaps unexpectedly, she's diagnosed with B-ALL. Now, as we mentioned, diagnostic evaluation test that is done in this case is the single nucleotide polymorphism array, or the SNP array, that shows low hypodiploid state. And the somatic panel notes a TP53 variant of unknown significance. And because at that time, low hypodiploid state and TP53 were a combination that would prompt, thinking about germline TP53, and we'll talk about that in a moment. There's a cultured skin fibroblast, so the gold standard test is performed for germline, for understanding the germline nature of this variant, and that test comes back negative. Now, one important aspect to this, and I'm sure we can come back to this later on, is that this very variant, that is, sort of variant of unknown significance, not in germline, put to rest, was actually reclassified within a year of her diagnosis to being likely pathogenic. So this dynamic nature of our world is certainly one that we have to keep in mind. So 16 months after her completion of ALL, she presents with pancytopenia and is diagnosed with monosomy 7 MDS with 5% blasts. And interestingly, the somatic panel that is done on the MDS now, there's no BALL in her marrow anymore, shows the same TP3 variant that is detected at a variant allele frequency of 45%. And indeed, when she has, MDS-directed cytoreductive therapy, after which very, very small, if any, sign of MDS is left in the marrow, this particular variant is still at about heterozygous variant allele frequency at 49. So what is this variant? Is this germline or not, is the question. So as promised, a couple of words on hypoliploid ALL and TP53. It is altered in over 90% of pediatric low hypodiploid ALL, and these are ALLs that have chromosomal numbers of 31 to 39, but they also might present as something called masked hypodiploid and appear to be hyperdiploid. Not important again for this discussion, but something to keep in mind. And it's very rare to find in other BALLs. And so in addition to it being quite common as a somatic genetic alteration, almost 50% or 43% of these patients also had this the variant in non-tumor cells, suggesting of a high association with germline TP53, which is and low haplodiploid ALL really represents a manifestation and may be the first manifestation of Li-Fraumeni syndrome. Now, Li-Fraumeni syndrome, as many of us know, is germline TP53 state with heterozygous mutations. And what this means really is that it's affecting all the tissues in the body. It's probably in the zygote, whether it's inherited or not, but it's really present in all tissues. And this is where the risk of cancer comes in every tissue of the body, and particularly pertaining to leukemia, the additional mutations lead to the cancer, typically with actually loss of the other TP53, for example, to leukemia. Now, another state that has been described in TP53 variants and also other mutations typically found in solid tumor cancer is this concept of post-zygotic mosaicism, where the TP53 variants may be found in some cells, but not all cells in the body. And what an unusual situation might be that the actual blood tissue, the hematopoietic tissue that is coming from mesoderm, for example, might be the only one that has the TP53 variant and acquires the additional mutations to go to leukemia. But for example, the buccal cells that you test or the skin fibroblasts that are very related in germline origin to blood tissues might be negative for this mutation. And this is in contrast to, for example, a somatic acquisition of TP53, which is basically coming from a wild type blood cell and then acquires the mutation later. And indeed, what this case was that of a post-zygotic mosaicism for TP53. And from the perspective of hematological cancers, these patients really behave like LFS in the blood, right? So Li-Fraumeni syndrome, but only retaining to the blood tissue. And in fact, the recommendation for patients who have post-zygotic mosaicism is to follow them like patients with LFS, because we do not know what is the extent of mosaicism, and we can't really sample every tissue to find that out. And so they're followed as such. And one question that I want to pose maybe for our discussion later is, in addition to germline non-hematological tissue testing, which is pretty standard, as I mentioned, in our world, should every patient with low hypodiploid ALL who has a TP53 variant have a remission marrow sequencing to kind of appreciate or document the presence or absence of post-zygotic mosaicism? So to conclude, I want to give you, again, just to summarize the clues that we use to recognize hereditary pediatric hematologic malignancies. And one of them is the pathological findings in the marrow. So the dysplasia, an AML that has dysplastic features, and hypoplastic, for example, hypocellular marrow that has dysplasia. Although, again, the exception for the rules, right? So not all dysplasia is disease. So recognizing that sometimes this might be part of the normal disorder is important. Multiple hematological or non-hematologic malignancies should definitely be a clue, whether it's a different type of cancer or has different genetics. And this is by no means to say that these are clues to like 100% diagnoses of hereditary conditions, of course, but these are things that you can increase your suspicion for it and test to be sure it's not the case. I mentioned the overlap genes, heterozygous or close to heterozygous clone size. And these are some of the genes that we could come up with, but certainly the list is not exhaustive. And so, thinking about some of these genes, when you see the somatic panel, be sure to explain and account for the clone size and make sure that it kind of matches what you would expect with the presence or relative to the presence of the blasts in the marrow. And lastly, the somatic landscape of genetic alterations, so how the cancer kind of evolved, or at least at what state we find it in, can be a clue. So an AML that has multiple STAC2 mutations is not really typical and should clue us in that there might be an underlying genetic condition that actually made this patient or resulted in this patient having multiple STAC2 mutations. Or, for example, a splice factor variant in a young patient with MDS quite unusual in pediatrics, and again, should prompt us to think about something that is underlying it. One amazing wheel of mutations or genetic alterations that I've adopted from Marcin Ledarski, who's at St. Jude, and I've been updating this over time for the past few years, is this idea that every somatic, every germline condition has a little bit of a favorite landscape of somatic mutations, and sort of we could use that echo, that landscape to actually understand or perhaps have our suspicion for underlying germline condition. And this is by no means exhaustive, and I want to make sure to highlight this other and variable piece of the pie that is the most dynamic probably in our world, and things change every day. And so this chart can be updated almost on an annual basis, and we'll have new things that are added to it. And then the tools to work up our suspected cases are really the comprehensive personal and family history that includes hematological and non-hematological presentations, comprehensive workup with labs. I mentioned including immunological assessment of lymphocyte subsets and immunoglobulin levels, for example. The bone marrow evaluation should be comprehensive. That includes not only the typical karyotype and FISH assessment, but also SNP array and a somatic panel that could prompt us to think about some of these findings. Appropriate use of germline testing and sort of using the correct panels and that involve the genes perhaps that we're suspicious for is important. And I already mentioned that negative somatic panel does not rule out germline condition. And lastly, I do want to stress again this idea of revisiting old testing panels. So if somebody has had a negative workup 10 years ago, might not be quite negative today because that germline panels are different, and the variants of unknown significance do get reclassified. So I definitely keep track of all the VUSs that I have in my patient cohort, and continuously from time to time just check up on these new variants or reclassification just to see if that has changed over time. So that is all for me. I want to thank you for your attention. I just want to maybe leave you with the additional references here that I didn't have a chance to specifically address, or reviews that I find useful for you to look at later.
Great. Thank you so much, Serene, for your presentation. I thought the cases were very helpful in understanding the signals one can look out for to suspect an underlying germline variant. I'm looking forward to our discussion now. Please, if you have any questions, go ahead and type them into the Q&A icon. And now I'd like to formally introduce our panelists. In addition to Dr. Avagyan, we have Dr. Chang and Kayla who are joining us. And I'm delighted that Dr. Chang is here, who is an associate clinical professor in the Department of Pediatrics, the Division of Pediatric Hematology Oncology at the University of California, Los Angeles. And Kayla Hamilton is a senior genetic counselor at the Pediatric Cancer Genetic Risk Program within the Dana-Farber Boston Children's Cancer and Blood Disorders Center. It's always a mouthful, these institutions. Please again, ask your questions. I certainly have some questions myself, and maybe I'll start with one of mine. I was curious when you presented the IKZF1 case, Serene, you mentioned that the pearl is to interpret and explain the clone size. So in that case, it was 87%. And I was curious whether in that instance or that scenario, whether there were other clues with that particular individual that now looking back, you would have said, oh, for example, did this, I think it was a male, did he have any signs of immunodeficiency or anything like that that would have helped?
So yeah, the answer is no, there were none.
Okay.
And unfortunately, this particular case also came to us sort of after the diagnosis. So this is digging back to what happened previously. I think it's quite hard with lymphocytic leukemia because the baseline immunological state is not quite normal from that, unlike in MDS or myeloid cancers, for example. So I think it would be hard to interpret. I think the red flags that I'm talking about would have probably been in the pink zone. I don't know if others would agree with that, but that's sort of, it's very, again, a lot of times the blast percentage is so high, right? You can make the math, but what I try to teach myself and our trainees is that don't base your calculations and your suspicions on math, and just test to confirm.
Got it. So, but yeah, so you do the math and then you think, okay, and you look at chromosome loss and you try to just put it along with the blasts. And then, so what you're saying is actually lean towards just testing because
Yeah,
it's one of those genes
exactly.
that we should just say, okay,
Yes.
let's just test.
Yeah,
Okay.
in fact, the second somatic TP3 case, which is super unusual, but I've seen it like 3 times here now in the last few years, was exactly the case. It was a TP3, 80 some percent. The blast count, you do the math, it sort of matches, and it just doesn't feel like that should be our leaning back methodology.
Mm-hmm.
Yeah.
I'm curious, Kayla and Vivian, would you agree? Do you follow the same sort of rubric?
Yeah, I think it's really hard because it doesn't always correlate, and we I think we've all had cases where we've been surprised with a lower VAF that ends up being germline, and vice versa. So when in doubt, I would always do a proper germline assessment.
Great,
Yeah,
thank
I
you.
agree. There's so many cases that we have where patients really don't fit the phenotype or have other features of the syndrome. So we never use like the lack of a family history or the lack of immunodeficiency or anything else to rule out a syndrome and really recommend testing if there's any variants that we have any suspicion could be germline.
Great, thank you. So in that setting, in that case, again, knowing this was like a historical case, had you identified that individual as having that germline variant, would you have transplanted then? Yeah. Okay.
I mean, that's it's a bit of a that's still up to discussion, and I think it still depends on availability of donors, etc. So I think that's not a standard of care yet, at least in many recommendations. And I've cared for patients who had conditions and were treated for standard risk ALL with successful treatment and were, a decade out once that syndrome was discovered, and exactly the same scenario in other institution might have been transplanted. Excuse me. And so, yeah, I think the jury is still out there. I think more and more, at least in our institution at UCSF, we do recommend transplantation at that point, if especially if a suitable donor is available.
That makes sense. All right, I have a question from the audience. So for the patient with T53 variant detected, did they end up being followed for Li-Fraumeni? Yeah.
Yes, they were referred to our clinic equivalent where Kayla is, which is the solid tumor sort of hereditary cancer center, and yes, they will have MRs as per recommendation of LFS. Yeah,
I didn't catch how frequent is this post-zygotic mosaicism? It can't be that frequent, right? Yeah, okay.
it's quite rare. It's quite rare.
Um, all right, we have another question here. I'm a second-year genetic counseling student at UCSF, and through my research, I have observed that many young adult patients, ages 20 to 29, have not had the opportunity to undergo a germline genetic evaluation. When I presented my retrospective findings to hematologist oncologists at UCSF, I noticed considerable hesitation around ordering germline genetic testing. As a physician, I'm interested in your perspectives on how we might improve access to and utilization of germline genetic evaluation for these patients. Um, I apologize that this topic is not directly related to pediatric hematology cases, but I would say you probably do follow
It
some in
is.
their
Yeah.
20s. Yeah.
Very, very much. I think our sort of upper end is at 25 range, 26 range. So these patients definitely come through our clinic, and we actually talk to very genetic counselors do not have an age limitation. So a lot of times, Kayla would attest to that. A lot of the consults that we get, that I get for sort of opining on is from patients who are young adults through our genetic counselors. So thank you for keeping an eye on that. Yeah, so it's a very tough situation. I think a lot of times, I don't know if you noticed in my presentation, I said buccal swabs were used for genetic testing, which I think for a proper, marrow failure predisposition specialist, that's sort of a taboo thing to do. But insurance coverage is a huge issue in young adults, particularly in a system like UC. And so we utilize a lot of times the germline paired testing avenue that has a buccal swab as an entry tissue that can be accepted as a way to do this. And I do encourage our colleagues to think, frequently about it. And I think it's just the education, Claire, and the constant sort of reminder of revisiting this idea. and just being aware that this might be a component. And I mean, there are some adult oncologists that would argue the frequency or the prevalence, I guess I should say, of the germline conditions now underlying adult malignancies is kind of like in the range of 15 to 20%. So it's a very considerable number to consider, particularly when related donors are considered for transplantation.
Yeah, thank you for that. Kayla, Vivian, do you have anything you'd like to add? And I'm curious if you, have the same sort of experiences within your groups.
Yeah, I think it's definitely something that many different centers have faced is really figuring out how to appropriately provide genetic counseling services for children, young adults, and adults with hematologic malignancies. I think some of the big things are educating providers about the potential benefits of identifying an underlying predisposition, the impact on screening for other cancer risks, the potential impact on transplant conditioning, donor selection, as well as for that young adult range that you were describing, really thinking about that's an age where people are starting to think about family planning, and being able to provide really helpful information as they're expanding their families or having their first children. I also think it's helpful to always remind providers that genetic counseling does not equal genetic testing. So through the genetic counseling, the genetic counselor can provide that risk assessment, help answer questions for these patients, but doesn't necessarily mean that genetic testing has to be done for every patient. So it doesn't need to overburden the system in that sense. I find that once people get behind the idea that they're not equivalent, it helps kind of ease people into accepting that a little bit more.
Oh, that's a great suggestion. Any thoughts from you, Vivian?
Yeah, I will just, echo everything that's already been said. But I just want to revisit the idea of like increasing awareness. I think there's still a lot of um, providers who think that the frequency of finding these HHMs is low, and so they don't think about it, or they do the somatic panel and they somehow think that is going to pick up the underlying, HHM. So I think just we still need a lot more education. And then in terms of utilization, I think if we can establish workflows where this is just done more routinely, getting a skin punch biopsy at the time of a bone marrow biopsy, or if we've tried to do this at our institution to varying degrees of success, but the more we can kind of make things routine, and not sort of based on an individual provider's interpretation of family history or interpretation of the diagnosis, or things like that, I think would be helpful. And I think the access in terms of insurance is a huge barrier as well, and I don't have a solution for that, but if we could do some of these other things, maybe it would help.
Thank you. Yeah, education is key. That was and adjusting workflows as you suggested, just making sure it's just built within the workflow and make it easy. I have a question. There's someone who is asking, can we please go back to the question that Dr. Avagyan posed at the end with the T53 case, because they'd like to hear the panel's thoughts, and particularly in terms of whether the person should, in that setting, additional testing on the blood and marrow when a patient has a T53, should you test at remission if the skin punch biopsy was negative? They would just like to hear others' thoughts on this.
I think we routinely do the hematologic malignancy panel at pretty much with every bone marrow biopsy. So that would potentially continue to pick up at the time it might have remained a VUS or something like that. So that may be sort of routine at our institution, but that case was just really a surprise. And it was a good thing that you were able to get it reclassified and bring attention to the fact that this VUS was now pathogenic or likely pathogenic. I don't know if that would have necessarily happened at all institutions.
Yeah, it was not me who reclassified, by the way. It was just reclassified, but in like a few months. Yeah.
Kayla, did you have anything you wanted to add to that?
Yeah, we now more routinely do a repeat somatic panel at the time of remission. So we would hopefully catch things that might have been absent on like a germline test on skin, but remained present in the blood and would be able to further evaluate for that. I do think about, that's a more recent step that centers are starting to take to do that routinely for patients with ALL. So it does make me think about previous cases and trying to make sure we didn't miss anything important for our older patients that are still coming back for routine follow-up.
Yeah, I think the key both for the genetic testing and for these is allocation of resources, which obviously is a huge component of this discussion that perhaps, again, I come from an institution that remission marrows were not even a question for testing somatic mutations, and I found myself in one that is actually not routine at all. And it needs to have a very huge discussion whether an additional genetic testing overwhelming the lab, overwhelming the insurance system, overwhelming everything is going to give you the information that you're worried about. And I think just trying to, I don't know, I call it the pick your battles piece is one. This is one that I really would push for. If you have
You're picking this battle.
Yeah.
Okay, thank you all. There was another question. We're focusing on the TP53 case. So another question around reproductive risk for an individual with mosaic TP53.
Yeah, I think it's the same for almost any germline condition where we don't quote unquote find, right, that I didn't mention that particular mosaicism, but it's actually called germ cell mosaicism, where you basically can have the mutation only in the germ cell and not be affected somatically. So a parent might have a negative blood, negative skin testing, negative blood testing, but the mutation is actually in the gametes. So yeah, this is a concern that it might be blood in a germ cell. There's absolutely no logic to mosaicism in that sense, although I don't know of any case with particularly TP53, but there's very incredibly rare cancers where there is a co-occurrence of germ cell tumors and a blood cancer that share genetic ancestry by mutational analyses, which basically tells us that at some point of time, these two tissues may come from the same place or time, or progenitor. So there's definitely a non-zero possibility for a germ cell and a blood cell to have the same mutation. Absolutely. Yeah, the human pathology has shown us that can happen.
Interesting.
Go
ahead.
TP53 not too infrequently, and we usually end up just saying up to a 50% chance for each pregnancy, but we definitely highlight the up to and that it could be much lower than that. We just don't know if the eggs or the sperm are affected.
Yeah, that makes sense. I know we're 2 minutes over time, but if you're open to just taking this last question, I would appreciate it. Are there any contraindications for donors who carry germline pathogenic variants and genes associated with emerging or moderate evidence of hematologic malignancies? The person lists, for example, CHEK2.
You mean for this individual to be donors for transplant?
Yes,
is that the question?
Yes, exactly. Yes. Do you consider, or you, I guess, would you, if you didn't have any other donors, would you consider them as a donor?
If this variant is shared by the recipient, that might be a discussion for sure. I've not seen CHEK2 yet in any of our situations, to be honest, to dig into that, but I think that would definitely require some understanding of that variant. Yeah, I would say yes.
I recently had the situation where a sibling tested positive for CHEK2. It was a very complicated case, and the patient had, we thought it was a secondary leukemia, and so she was needing a transplant. But in the end, because there were other donors, unrelated donors that were good matches, it was decided to not use the CHEK2 carrier. But I think if there were no other donors, I think then it would be sort of shared decision making and a discussion of all the risks and with the patient, but very tough one.
Yeah, that is a tough one.
And it's actually, the opposite is true too. Sometimes we overreact to variants. RTEL1 variants are extremely common in some ethnic groups. And so even if it's a VUS and you have a suspicion that the marrow failure or the MDS is related to that, finding that variant in a family-related potential donor, it definitely, I'm not talking about pathogenic here. Sorry, the question might be related to pathogenic variants, but for the VUS especially, I think we sometimes actively do not use donors that might be actually better for the patient from perspective of transplant outcomes because of our, kind of fear that this might be related to the pathogenesis of the disease.
Yeah, they're complicated discussions, right?
Yeah.
All right. Well, thank you all for your time. Thank you, Serine, for your presentation. Thank you, Kayla, Vivian, for being here for the panel discussion. And hopefully we were able to educate a little bit here with this program and improve on diagnosing these cases. So thank you very
for
much.
the invitation.
Yeah. All right. Have
Thanks
a good
for
day, everyone. Take
participating.
care.
Bye.
Yeah. Bye.